Morning, everyone. This is Chris Boyle from DPH. Thanks for joining us today for this news briefing with Commissioner Giuttani. What we're going to do, if everyone can mute themselves, and then Commissioner Giuttani is going to say a couple opening remarks, and then I will go. We will go around the horn here. I'll call on each of you to ask your question regarding the latest monkeypox update. So let's start off right away. Like I said, if everyone can keep your cameras and mics off, and then unmute yourself for your question. And I'll turn over now to you, Commissioner Giuttani.
Okay, great. Thank you, everybody, for joining us today for this briefing. The reason we wanted to have this opportunity for all of you today is because we wanted to let you know that cases of monkeypox are rising in Connecticut, so that we are at 12 cases today from overnight. And as you may have heard as well, our state public health lab has been doing the testing for monkeypox, but there are 4 other commercial labs that are coming online as well that will be able to do up to 10,000 tests per week. So we will start having the ability for different labs to be able to do testing as well, and this will contribute eventually to the overall numbers. There's a CDC map that includes the updates on the numbers of cases on a daily basis. And so this will be the most accurate way to determine what our running count of monkeypox cases is. The main things I wanted to highlight today are that although monkeypox can be transmitted to anybody could get monkeypox, and it is transmitted through close personal contact by and large, in that skin-to-skin contact has been the most common way that this infection is passed. What we are seeing is that current cases are primarily spreading in social networks of gay, bisexual, and other men who have sex with men. And so our efforts right now are focused on making sure people in those communities first are most aware of the risk that are happening in that community, but also to be aware. So for the general population, the overall risk to the general population is low at this time, but we are continuing to moderate and monitor this very closely. In terms of vaccinations, we have been given an allocation from the federal government of Jynneos, which is the most well-tolerated vaccine that is available on the market. And as we have cases identified and their contacts identified, we are providing the opportunity for vaccination for post-exposure prophylaxis to those individuals. We received those allocations as we order them from the CDC. We are identifying places around the state where we will be able to administer vaccines for those who may be exposed. And this is the area that we're focusing on very strongly because we want to try to contain and prevent as much infection as we can. However, as those cases are being identified, if somebody is more immunocompromised or at risk for potentially having more severe case of monkeypox, there are treatments available as well. This is also a process that we go through with the CDC, where we are able to request and receive allocation of the most commonly used therapeutic, which is TPOXX, and we then have a process that we can get that to a hospital on site for an individual patient who may be at most risk for having a worse outcome from monkeypox. So the point of this communication today is really to raise awareness. I don't want the general public to be alarmed, but on the other hand, we need to be aware, and also to have confidence that we as the Department of Public Health are doing a multi-pronged approach, which includes identification of cases, contact tracing, allowing for vaccinations for those who have been exposed, and then enabling for treatment for those that are immunocompromised and may have more severe cases. To date, we do not know of deaths that have occurred from monkeypox in the United States. Hospitalizations are rare. When they have occurred, they are usually due to either bleeding or pain control. And in general, people have been recovering from this illness. But this is something we're going to need to moderate and monitor very closely as we go forward in the weeks ahead. So, Chris, I will turn it back to you for individual questions.
Great. Thank you very much, Commissioner. We will start off with NBC Connecticut, News 8 will be in the on deck circle. NBC.
Hi there, guys. Good morning. Thank you so much for taking the time to talk to us. I know you had mentioned that anyone can get and spread monkeypox, but again, the current cases primarily spreading are in the social networks, as you mentioned, of gay, bisexual, and other men who are having sex with other men. However, there are some women who have now gotten this. But can you just kind of talk about the percentage and the risk of getting this if you're not in that group? So for folks who are in that group, what is their percentage? And for folks who are not in that group, if you could compare, because, we've been seeing some conversation of people who are worried, who are concerned. So would love to be able to say, what is the percentage of you getting this if you are not in that group versus are being in that group?
So I can't give you exact percentages. What we go by is data that the CDC compiles from the various states on epidemiology of patients that are identified with this infection. And what we can say from that data, so there's a subset. Let's say we have a total population of cases nationwide. There's a subset where the CDC has this information. And the vast majority on that subset of patients where we have that information is men who are having sex with men. So that is why I say that I can't give you an exact percentage, but it is the vast majority of cases that are men who have having sex with men. Now, having said that, why do we need to be alert in the other population? Because could it be possible that you have some skin-to-skin contact with somebody at some point who had monkeypox? It's possible, but it is very unlikely right now, which is why we are trying to contain the infection in this population or target our strategies in this population to start.
And also, can I just ask a follow-up question to that? So if someone had monkeypox, and I'm sorry if you mentioned this, if someone had monkeypox, how long does it take for them to recover? And, if someone then has sex with that person or has intimate contact with that person after them having it for 5, 10, 15 days, are they still likely to be able to get it?
So again, this is one of these situations, as many of you know as reporters, that science evolves with an infection that we are still learning about because it's being transmitted in a community that we have not seen before. So what I'm going to say right now is the best information we have at this point in time, which is that as long as there are lesions that are active, there is a potential risk for transmission. And therefore, we are looking in most cases of at 2 to 4 weeks for recovery for patients that are in this infected group. Now, what we also know is that it has been identified that the virus can be, for example, in seminal fluid. So the question is, how long would it be there? How long could it be infectious? The reality is we don't have a firm answer to that, but 2 to 4 weeks of recovery time is a fair estimate for somebody who's had monkeypox to be as safe as we think we can be and feel comfortable that the infection has resolved.
And do you have an ultimate message to people who are listening to you today? Is there one message that you would have for the general public? Because people are coming off of COVID. I shouldn't say coming off because they're still dealing with it, but people who are dealing with COVID and may now be fearful of this, what would your message be to them?
My message for the general population would be that at this point in time, this is not an infection that I think the general population should be scared about. However, be aware, alert, listen to what we're saying and see how this infection may evolve. Right now, it is vastly limited to the community of men having sex with men. That could change with time, but we do need to try to do our best effort to control the infection from spreading beyond that.
Thank you so much. Thanks, Chris.
Great, thank you. Up next, News 8. Anyone from News 8? Okay, we will go on next to Connecticut Public.
Hello, Commissioner. With the information that you have so far, are there any conclusions that you can draw about how the extent to which this is spreading in Connecticut, sort of beyond those 11 people? If you have any sense as to how many of the people that get this are actually going to their doctor and reporting it and getting it reported or getting into the system.
So I think one of our biggest challenges is until people come to attention, we don't know the scope of what is beyond that. What we can say is we have seen a lot of cases in New York. Many people who have been infected have been to events in New York. And so we can anticipate that for people who may have had exposure or been exposed in settings in New York, they are getting identified as we are moving forward. We see cases that have evolved in Fairfield County, New Haven County, Hartford County, and we want to be aware of potential contacts with other people who might have been infected in other localities. So Massachusetts has had more cases than us. New York has had more cases than us. One of the major reasons for expanding testing is to allow as much opportunity for people that may have been exposed in settings like that to be able to have the opportunity to be tested. And so really where we've been focusing our efforts is to raise awareness both for the public and for providers. We've been doing a lot of provider education so that, number one, people go to their providers, and then providers actually consider this diagnosis and actually try to send a test. And so one of the other major things I want people to also know is that if you are not symptomatic, you are not infectious. And that is good news. You know, a lot of people have heard over the last several years with COVID about having asymptomatic infection and not knowing if they are infected. The science right now would tell us that if you do not have symptoms, you're not infectious. So that is good news, because if you do have symptoms, again, this is both the patient education and provider education. If you do have symptoms, please present for medical attention. And, you know, one of the things that we have seen throughout the country in cases that are being identified is that some patients are presenting with rectal lesions. They may not have vesicles or other rashes in other parts of the body, and this is resulting in rectal bleeding. This is an example of something that may not initially register as a clear sign of monkeypox, but it could be. So this is the type of thing where we want to make sure that we are educating both patients who might be involved in having men who are having sex with men, and potentially providers who may not be thinking of that at the top of their mind. So those are the types of things that we want to make sure the community is aware of.
And for the people that have become infected so far, do you have a sense as to whether are you seeing sort of this transmitting within those groups of people, or does it appear to be jumping and infecting other people and then just only occasionally kind of getting noticed or tested?
So what we've seen is that, again, the vast majority nationwide have been men having sex with men. There are bisexual men, bisexual women who may have been involved. This type of interaction, again, but it's skin to skin contact is what we're looking at. These are the types of situations that are the vast majority of cases. And so we will continue to identify cases by people presenting. We want to make sure that people understand there's no shame in this. I want people to feel comfort to go to their providers, to go and seek out medical attention, to go get tested so you can get the care that you need, and we can help protect those that you may have been exposed to, who may have been exposed. And the more that we normalize this and make people realize that it is okay to go get tested, it is okay to go to your provider to seek that testing and evaluation, that is the way that we will be able to have a better sense of the number of infections that are out there and the transmission that's occurring. But again, the major take-home point is the vast majority of cases nationwide are in these social networks.
And are condoms an effective way to prevent transmission of monkeypox?
So I certainly would recommend that condoms and safe sex are a mitigation strategy for any number of infections. And what we think with monkeypox is that, again, if there are lesions, penile lesions, for example, or there are rectal lesions, for example, that this could be a protective strategy. So My advice would be that using condoms is helpful for so many things. Monkeypox may be one other thing that it could be protective for. And so we want to really use the full armamentarium that we have, prevention being one of them, and condoms are certainly in that arsenal.
And with the number of cases that you have seen so far, I mean, are there any other sort of conclusions that you can draw, or how concerned does that make you? Is this about where you were expecting we'd be at this point, or is this not as bad? Or, and that's my last question. I know other people have questions here as well.
Sure. So what I would say is that we took a while to find our first case, and that's why we were spending so much time in provider and patient education and trying to encourage people to come forward and have providers suspect monkeypox, because there were cases emerging around us, both in New York and in Massachusetts and around the country. People are traveling and around the world. But we do anticipate, now that we have been doing this education, having forums like this, making awareness go up, that we will see a rise in cases. That is to be expected as we go forward.
Okay, thank you. Up next, WFSB.
Hey, Commissioner, can you hear me?
Yes, I can.
Thank you for taking a few minutes today. My first question is on vaccine doses. How many doses does the state have right now? I know you're expecting some more soon, but how many do we have right now?
So we were allocated over 600 doses to start in the phase 2A allocation from the federal government. Before that, we were receiving doses to vaccinate people who had been exposed, people who may need to be laboratory providers of the testing. And then we're receiving 400 plus vaccine doses a little bit later in the 2B vaccination cycle. But again, these are in a rolling basis. So we order them as we have people that have been exposed and that we identify who need to get vaccinated. So that's what we're looking at right now. Again, those are doses. We have 2 doses for every patient who may have been exposed or person who may have been exposed. So the series is 2 doses. That's what we're looking at this point in time.
And forgive me, Commissioner, because I think it just cut out for a second, but you mentioned 600 for phase 2A and 400 for 2B. When does 2B start?
Yeah, so it's a little bit more than 600 and a little more than 400. That's just, round numbers to give you to start. But what I would say is we've been told that they wanted to be able to get out the doses as they had them, and since they or make them available. So we don't really know the timeline on 2B yet, several weeks away. But what we're hoping for is that we will get confirmation by the end of July on when that might be in terms of the 2B allocation that we have been given.
Great, thank you. And the 12th case, confirmed case, I know in the press release we got with the 11, everyone in that that has monkeypox is between 20 and 50. Is that 12th person also between 20 and 50?
I believe so, but we can check while we're on this call and I'll confirm. But yes.
And I was also just curious. Sorry. I was just curious if the 12 of you.
I'm sorry, the 12th person is in the same age group, just to confirm. Go ahead.
Thank you. And have you noticed in that age group, if the majority of that 12 is in their young 20s or their late 40s, have you noticed a trend there or not really?
Not really. I mean, I think that we have a spread in that age group, but the risk factors have remained the same in that age group.
And I know in the release you mentioned all of them are in Hartford, New Haven, or Fairfield counties. It's a pretty big piece of land there. Have you noticed any trends with the cases in terms of a specific city or anything like that?
So we have not seen any specific trends. However, what I would say is, looking at the overall group, probably people in their 20s are a little bit more overrepresented, but also I would say that we often see, as we saw with COVID, things come up from New York City. And so there's no specific preponderance, but I think that, Fairfield County, if you can see, it goes along our highways. I mean, along Fairfield County, New Haven County, and then Hartford County. So I think exposure to events in New York City where we know the vast majority of cases in New York have occurred has been something that is a risk factor for sure.
And my last question, Commissioner, is out of the 11, you mentioned the vast majority have not been hospitalized. Do you have a concrete number on how many of the 11 or now 12 have been hospitalized because of this?
I believe it's two. I believe it's 2 cases that were hospitalized.
Okay, thank you very much. Appreciate the time. Thanks.
Sure.
Great, thank you. Up next, Connecticut News Junkie.
Hi, Commissioner. Thanks for doing this. So explain how you're doing outreach and education about this to the population that is most impacted.
So we have several ways that we are doing that. For several weeks, we've been working with partners that we have through DPH, specifically, for example, through our HIV clinics, Planned Parenthood, syringe exchange programs. These are just places where various different networks may go through, but these are contacts that we already have. And we've been working with providers that provide care in certain communities to be able to both communicate with their patients and for the providers to raise their awareness. We've also done provider communications to the provider group at large. So as we said, any patient may go to any type of provider. So we've been having provider communications, meaning emails and also info sessions where people can come and listen to our DPH staff to be able to get further educated. Another way that I'm going to be doing that is partnering with our legislators and with community groups who have connections with these types of at-risk populations. So that's something I'm going to be doing today with outreach with specific groups. So again, we want to be able to get this message out. I want to do this today before the weekend is coming again, when people have time off and time to be able to do all the things that they are, tired of not having been able to do in COVID, which I really do understand. In addition, we have a monkeypox website that is up that people, and I encourage all of you to spread that as well, because I think that we want to be able to have as many resources. The CDC has their resources, which we certainly link to, but DPH has a monkeypox website as well. So I ask for you to partner with us to be able to get this information out there so people understand who the most at-risk groups are and who the potential, other groups are that need to be aware of this. So those are some of the major ways that we've been doing this going forward.
Do you think this is hard? I mean, obviously it is targeting a specific population. Have we been handling this better than we handled, the HIV epidemic, back in the late 80s?
Well, I wasn't around in the late 80s to say exactly how the initial implementation went down. Obviously, I was, a medical student when a lot of this was happening, and actually in the 80s, a high school student. What I can say, though, is that we have raised awareness. We are partnering with the relevant groups. I feel that we have brought all the people to the table that can be helpful in trying to do outreach. Again, this is not a sexually transmitted disease per se, but because it is communicated through skin-to-skin contact and started in that group in Europe and then in the United States, we are seeing a proliferation in the disease in this population, which is why we want to capitalize on those networks that were set up through HIV that we know as an infection that is in that specific group where it started originally. But just like HIV, other people are at risk as well. So I do think we are doing better. We are raising awareness. Again, we have treatments, we have vaccines, and it has been largely a self-limited and milder disease, which is all good news, and people do recover.
Thank you.
Great. Up next, News 12.
Hi there, Commissioner. When we talk about administering this vaccine to close contacts of infected people, what do we know or what can we guess about the efficacy of this vaccine after exposure?
So that's a great question, because we have not had an outbreak of this scale, of this magnitude, and we have not really had the data to fully answer that question. We have data from, scientific studies that were done with a challenge of a different virus, so we can make certain conclusions, we can make certain assumptions based on that. What we can say is that we do believe if you receive the vaccine within 4 days, that we can prevent infection, which is why we're trying to capture people within those first 4 days as best as possible. However, if you get the vaccine up to 14 days after your exposure, we feel that we should be able to lessen the severity of the illness, which is why our first goal is to get people within the first 4 days of their exposure to try to get them a vaccine to prevent infection altogether. And if not, to get them a vaccine within the first 14 days to try to have a milder course of disease. As people receive vaccine and this plays out, we will get more data and we will report that data in terms of if there were breakthrough cases of people who've been vaccinated to the CDC so they can compile more information on the efficacy of this vaccine.
Excellent. And as supplies become more available, would this vaccine become more widely available or widely recommended?
So I think we're really focusing on our first groups because of what we anticipate the vaccine availability to be. If more vaccine becomes available, if the risk of infection becomes more broad, then we will adapt and modify and change those recommendations as we go forward.
Thank you, Commissioner. That's all I have.
Thank you.
Great, thank you. Up next, Fox 61 in Hartford. Fox 61. Okay, we will move on now to Fox News. What about WTIC AM? And then lastly, patch.com.
Yes. When will those commercial labs come online in Connecticut for testing?
So we have 3 labs for sure already up and live by my update last evening, which includes Mayo, Quest, and the first lab that came on was LabCorp. Sorry. So LabCorp was the first one that came on. After that, we also have the other 2. And then the fourth one, which is Aegis, is the last one. I do not know if they're already live, but what most of these labs are doing is they are dedicating one site in the country to do all of the testing. So as I've explained, these tests need to be done in a very controlled way. And the person who's doing the test needs to be vaccinated. So these commercial labs that have come on board in general have identified a specific site in the country where they are going to run tests. And so actually all 4 of these labs are now live. And so what a provider can do is send that specific test to that provider. Let's say you're going to send it to LabCorp. LabCorp will then send it to the site where they are running this test, and then they will be able to report it back. And so the turnaround time in general, I think, is being reported at around 3 days for these tests. For providers, in addition to that, our state public health lab is doing tests from Monday to Friday, and providers can send these tests to our state public health lab, which will also be able to run the tests. Turnaround time may be faster, but not as easily accessible as maybe if you are used to sending something to LabCorp or Quest or something like that. So our state public health lab is also a full partner in this. You do not need approval to be able to send it to our state public health lab. If as a provider you've identified a lesion, you can just send it on over, and Monday to Friday it will be run. The one thing I do want to alert people to is that these tests are not free. So they will be charged to insurance, or if somebody's uninsured, to the patient. And how much the insurance will pick up, I don't have specific answers to that in terms of specific insurance plans. I also do not know exactly what each lab is going to charge for the test. But these are available. They can be sent to these 4 labs now that are live. In addition, from the beginning, like I said, our state public health lab is available. Initially, we were requiring an approval process where you called in. However, we are no longer requiring that. We've listened to the feedback of providers, want to make this as easy as possible. If, as a provider, you take a test on a patient, you can also just send it to our state public health lab in the state of Connecticut for a patient that is in the state of Connecticut.
Okay, great. Thank you. Christine from Connecticut News Junkie, is that another question you have your hand raised for?
No, sorry, I didn't take my
Okay.
hand up.
Dylan, WFSB, do you have another question?
I actually do, if you don't mind, Commissioner.
Sure.
So, Commissioner, you mentioned the physical contact, and you mentioned obviously the men having sex with other men. I'm just wondering if someone that has monkeypox and doesn't know they have it makes that physical contact with somebody else, how long does it take for the second person to develop some of the symptoms or the rash, the potential lesions, things like that?
So what you're saying is if somebody doesn't know that they have lesions and has contact with somebody else, is that correct? Is that what you mean?
Or I guess if, obviously it's being transmitted through this, or, physical contact, someone that doesn't have it then is exposed or is with someone that does have it. How long does it take for the person that doesn't have it to maybe start feeling some of the symptoms and develop the rash and things like that?
So if you've had contact with somebody who's been infected and has lesions, you can get symptoms up to 21 days after that exposure. However, for most people, it's probably happening within a week of exposure. So for most people, that incubation period is much shorter, but the traditional rule of thumb is that for up to 3 weeks after contact, you may be able to develop symptoms. So I think one of the key things that we need to remember here is sometimes it's possible that somebody has lesions, but maybe they are small, maybe they haven't fully matured, maybe somebody doesn't recognize that it's a full lesion, but maybe that could be the beginning of an infection. And if there is such a rash and you have exposure to somebody else, and maybe you didn't quite know that you had it, or it wasn't bothering you as much, or you thought it was something else, or you were sort of, writing it off as not something very important, it's possible that that infection could, touch somebody else get exposure through that up to 21 days, but more likely somewhere around 7 to 10 days.
Thank you very much.
Okay, Michael Freeman, NBC Connecticut.
Hi, Commissioner. Thank you so much again for talking to us. I just have one more question. Something that been mentioned earlier about 10,000 tests per week. Can you just mention that one more time just to clarify what that was?
Yes, absolutely. So one thing to remember is that this type of testing has been very reserved in what's called the Laboratory Response Network, which is something the CDC set up in order to test things that are in the smallpox family. As people know, smallpox has been eradicated. It could be used as a bioterrorism agent. That is why it's been a very restricted lab test at the CDC. And in general, like our state public health lab, there are Laboratory Response Network, or LRN labs throughout the country. And that capacity has been 10,000 tests per week to be done in those LRN labs. Now, what each of these 4 other labs, commercial labs that have been brought on, that have been given this protocol of how to test for this, so including LabCorp, Quest, Aegis, and Mayo. So those 4, LabCorp, Quest, Aegis, and Mayo. Each of those 4 labs has also said that, similar to the LRN network, they will each do up to 10,000 tests of monkeypox per week. So we are now going from 10,000 tests per week as a capability to 50,000 tests per week as a capability, with one more commercial lab that is supposed to be coming online as well. So with that much additional test capability in the country, we are hoping to be able to identify as many cases as possible so that we can try to contain this infection. Because as everybody's learned from COVID, the more you can identify the cases, the more you can contact trace and hopefully limit the spread of this infection further.
So, and also we just had another question. We had a viewer contact us, and she said, essentially she claims that she has monkeypox, but she can't get tested because the Department of Health told her that that they don't have swabs. Do you know if anything similar to that or what that could be?
So in general, what we've been doing is providing swabs, providing the necessary equipment to providers who can then use those swabs to appropriately get a sample. It's very important for a provider to do a sample because it needs to be sent in a specific way, in a specific type of tube. We can't just use a Q-tip or, you know, any other kind of swab. So this is why it's very important. This is why our education has been focused both on patients who may have symptoms and providers. And so what we want patients to do, and in this case, what I would encourage your viewer to do is to go to a provider who can take a sample of that rash and send it either to our state public health lab or to any one of the 4 commercial labs that are also online and be able to get tested.
Gotcha, with that as well. And are there going to be more swabs being sent out to providers or more tests being sent out to providers?
So we have plenty of swabs that have been sent out to various different providers. One of the other things that is evolving in this process is that certain labs are able to use certain type of media, for example, that they need to be able to do the test, and other labs are able to use their own media. But regardless, for any provider, if you do not have samples, please contact our state public health lab. We are more than happy to send out additional equipment for whatever you need to be able to send swabs to us for testing.
Gotcha. And again, it is factual to be able to say that the couple of signs people should look out for when it comes to this disease are rashes that look like pimples or blisters. Is that correct still to be able to tell people that?
Yes, that would be accurate that, you know, for rashes that look like vesicles, they look like sort of bigger pimples. I wouldn't say that sort of just your regular pimple that people might think of would really be it. What we're talking about a little bigger than that. So what we would call a vesicle or a pustule. So these are pus type filled lesions that people may be used to seeing. You know, we all get pimples sometimes on our body. That's really not usually what happens. But what I would say for anybody is that if something is not improving, if something is evolving, if you are getting more lesions in more parts of your body, that would be concerning. So if you thought originally something might have just been an isolated pimple, but now it's moving and it's going to other parts of your body and making you feel more uncomfortable, that would be reasonable to be evaluated for. Particularly, we have to remember if you have had contact with anybody, and sometimes, you know, you may not know exactly what the contact that you may have had, if somebody had that infection or not. But if we keep in mind where this community is, who you've been in contact with, who you may have had skin-to-skin contact with, those would be your biggest risk factors. And if you've had no contact like that whatsoever, or no skin-to-skin contact with anybody, then I think if you develop a pimple, that is very low likelihood to be monkeypox, if you've really had no contact, skin-to-skin contact with anybody.
Perfect. And again, this is, again, skin to skin, not as transmissible as COVID, for instance.
That is correct. And, you know, historically for monkeypox, it has been said that respiratory transmission is possible. However, so far that has not been what we have generally seen, but theoretically possible. And even if it was, it's really prolonged face-to-face type of contact that we're talking about. So I don't want people to equate what we are going through with monkeypox to what they have been living through for the last 2 years with a respiratory virus like COVID, or with other respiratory viruses that we know, for example, flu, or various different respiratory viruses that people are used to. This is primarily a skin-to-skin contact type of exposure.
Perfect. Thank you.
Okay, we have a hard stop at 10:15. Are there any last questions? If you'd like to raise your hand for Commissioner Jutani. Go ahead, Matt from Connecticut Public.
Given that this is transmitted by the skin-to-skin contact and not a respiratory virus, is there a possibility of this kind of being brought under control and kind of eliminated, or is that really not a possibility?
So what people may remember from the beginning days of the COVID pandemic was that we were trying initially for containment. Containment is exactly what you just described, Matt, which is that we want to try to identify anybody who's had this virus and be able to do contact tracing and eliminate it. I am getting concerned that we may not be able to achieve containment and that we will move towards mitigation. Mitigation being that we want to try to capture as many cases as we can and mitigate the spread of this virus. But unfortunately, we think going back now in time that it's possible this virus was circulating at low levels, potentially in Europe, for some period of time. We really don't know the answer to that, what the initial introduction was. And I think that because of COVID, it could have been that people were not interacting with each other as much. And so therefore, the interaction and the spread was happening at low levels and it wasn't quite recognized. And then it entered this community of social network, men who are having sex with men as an example, and started spreading more rapidly within that community from Europe than to us here in the United States and now throughout the United States. And so we do really want to try for containment. We don't know if we've gone beyond that or not, and if we are going to be left with trying to mitigate this virus going forward. But our efforts are still towards containment at this period of time, recognizing that we are going to identify more cases probably every day going forward now.
And would the next few days or weeks be sort of crucial in Connecticut for whether this becomes a containment issue or not?
So absolutely, in the sense that we want to try to identify as many cases as possible, as quickly as possible. That's why getting this testing capacity brought up to speed is important right now. What only time is going to tell us is the speed with which we continue to see more cases, and behavior will be able to dictate that. Prevention measures, somebody asked about condoms. They may not be foolproof, but they certainly may be able to help. So how we modify behavior and other mitigation strategies along with vaccination and treatments are going to be ways that we can try to contain this particular outbreak the best that we can.
Thank you, Doctor.
Great. Thank you, Commissioner. So if anyone has any follow-up questions, you can just email them directly to me and I can have one of our subject matter experts answer. So Commissioner, thank you so much. And everyone today, thank you for being on the call today. Everyone have a good weekend. Thank you.
Thank you, everybody.